Well, that gets sold out. We're never gonna know what finishes market.
Just they cannot mention to the comments today what that is. And they're just like, yeah, that's point. I mean, like, we'll build a rocket for competition, but we want to make test launches. Also, well, because
That's what you're saying,
yeah, we're not together to build. You're saying we're in the bottom of the fire rails or anything.
That's a bad setup. But I was looking on Blue Raven. We could just do a full deliberation.
Okay. How much is it for?
Exploration.
Well,
No, but three. You can only order three.
oh, nice. Oh, that was cool.
Three alternatives. Because the idea was to Blue Ravens first city. And do a something like that and then Blue Raven second. One of our something should be a pair.
Yeah, well, that's how the time itself, you just go in 17. And realistically, we can get one.
Yeah, we have that. That's just a thing.
That's only the other stuff. Yeah, the only the other, that's right.
You could totally just.
So technically, if you
Still
want,
fine, doing things on the start, really, for one hour.
it's a whole new, but realistically,
No issue with GPS.
yeah, I was thinking about it.
And then you see, me and Marvin, that's just so smart. They have a, you can do the your GPS.
Yeah, the one.
Yeah. Just a little.
It does.
It'll do with like an antenna.
Yeah, and it just does GPS, and that one also can.
And you come with like there's a thing called a ground station.
Oh, yeah.
So like once it's the ground, you like, you point it and it'll like, the light will turn green, or you want it towards it. So.
You can use it. I feel like
That whole setup, you can get two GPS, two batteries, and a little handheld sensor for, I think it was like $5.15 or something. So, because I know anything that goes over like 2,000 feet has to have the district, which both those sources are. So, and also just.
not to never see it again.
So,
Yeah, it's good. I mean, so we can just do tell me in the first, the second stage. One move there with GPS and sector.
because I did look, something was sold out at the,
Forward, so
there's, I mean, yeah, we're having.
All right, it's 4 o'clock. Let's go and get started. A great audience today. There we go.
I know at least 2 more people.
All right, sounds good. Sounds good. All right, good afternoon, everybody. How you guys doing today? Hanging in there?
Yep.
Busy times, I know. Okay. So I guess for today, we're having a relatively chill day today, so I just have slides for you guys today, so there's no notes to be taking. Of course, you're welcome to take notes if you want as well. But all the information is on the slides. So today we're going to be talking about cardiovascular diseases and cardiovascular medical devices. And so we have I have a lot of nice pictures for you guys, maybe answer some questions about maybe a family members who have high blood pressure, high cholesterol. We'll talk about some information about those, what kind of effects these diseases have on your cardiovascular system and how they connect with fluid mechanics. And so I was going to say it's a fun lecture, but it's not. It's when you're talking about diseases and people potentially being sick and dying from them, maybe that's not as fun. But at least there's no math today. That's the main thing. Okay. So announcements. So remember to please choose your final project topic by tomorrow. So I think the poll ends by tomorrow. And then what I'll do over the weekend is I'll send you your image data for your midterm project. And then that's going to be your topic for the final project as well. Okay. So what I'm going to send you is I'm going to be sending you a set of medical image data. So a CT scan, very similar to the tutorial that you guys just completed. I'm also going to be sending you a PDF report on the particular patient that you'll be having as well. And so, so the nice thing about all the image data that I'm going to be sending to you guys is that all of these patients already have models built for them. And so inside the PDF, you'll see a picture of the model that an expert has already made. So that'll serve as a reference for you guys. And so as you guys are making your Simvascular model, I think one question that everyone always has, like, am I doing this right? Am I doing this well? So the PDF will have pictures of the completed Simvascular model, which you can use as a reference. And so not only that, it has information about kind of the rough demographics of the patient. So whether they're a kid, an old person, what kind of disease that they have. And so, for the most part, most healthy people don't get a CT scan of them because there's really no need for them to do that. And so for most of the patients that you guys will be having, they went into the doctor for a particular reason. So they have some kind of disease or some kind of condition that, that they needed to get a scan for. And so, so definitely pay attention to that. And that's kind of why I'm having this lecture today as kind of timed well for that, so that, you can read that report and kind of understand a bit about where your patients come from. Because it's not really going to factor into your midterm project. Your midterm project is just really just constructing the geometry for your Simvascular model, but it is going to factor into your final project, where we're going to start to run simulations and get results, compute things like wall shear stress, oscillatory shear index, velocities, flow rates, pressures. And so, all of that information can be correlated with the disease. And so I want you guys to read the reports that I send you, and then, start to think about kind of what the kind of patient that you have and what kind of information that you want to look for in the simulation. Okay. Okay. So make sure you send me your project by tomorrow. If not, I will hunt you down and make sure that you choose something, or maybe not. Maybe I'll just give you something that's really hard to do. So, so if you want something that's reasonable, make sure you fill out the poll by tomorrow. It literally takes 2 seconds, so just make sure you do that. Okay. The other announcement I have is that homework 2, the lump parameter problem set, that's due next Friday. There was a small typo in my in problem 3B in particular. So so I did just update the problem statement on Canvas. And so if you've already started, or if you've already downloaded the problem set, make sure you just download the fresh one that I just posted just literally about an hour ago. Okay. All right, any questions I can answer before we get started for today? Okay. All right, so let's go and get started. And so, like I mentioned, today's topic is cardiovascular diseases and medical devices. And so we're going to be talking about some of the most common cardiovascular diseases, kind of how they form, what effects that they have, and a little bit more about the biomechanics behind those. And then for the second half of the lecture today, we'll be talking about medical devices. So some of the most common devices that you've seen used in the cardiovascular system. Of course, many of you have already kind of written that mini report that was part of homework 1. So now is your chance to kind of get an overview of kind of all the devices, or a good overview of a lot of the devices that are used in the cardiovascular system. Okay, so what do I mean by cardiovascular disease? Because cardiovascular disease is actually a very broad term that can be used to refer to a lot of different types of conditions and pathologies. So cardiovascular disease, at least the way that I define it, is a general term that refers to any abnormality in the cardiovascular system that causes a disruption of blood flow. Okay. So there is kind of a nice kind of base state that your body likes to maintain in terms of blood flows and blood pressures to make sure that all the blood gets to the different parts of your body that it needs to. Any kind of, either geometric disruption or any kind of, fluid mechanics disruption that kind of disrupts that kind of nice pattern, I consider that to be a cardiovascular disease. Okay. And a lot of times these cardiovascular diseases, or I say all the times, they lead to either negative health consequences or even loss of life or quality of life. Okay. So cardiovascular diseases in general is a major cause of death worldwide. It accounts for up to 50% of all the deaths worldwide. Okay. Some kind of cardiovascular disease in general. And as engineers, what we're interested in is kind of the biomechanics, or kind of the formation of this, the formation and progression of these diseases, so that we can better design devices and treatments to help these patients that are suffering from these diseases. Okay. So there are a wide range of diseases, and so the ones we're going to focus on mostly for this class are the ones that are kind of more mechanical in nature, so the ones that have strong links to fluid mechanics. So the ones we're going to talk about today are hypertension. So hypertension is another name for high blood pressure. Atherosclerosis, so that's another name for plaque disease. So you might have seen, commercials for Honey Nut Cheerios growing up where they showed, plaque buildup in your artery. So that's atherosclerosis. And we'll talk about kind of one of the more interesting diseases out there, which are aneurysms. Okay. And then later on, we'll discuss common medical devices that are used to treat these diseases. Okay. Okay, so let's start with hypertension. So hypertension is kind of the medical term for high blood pressure. So high blood pressure, I think, is one of the most common cardiovascular diseases that a lot of people face. Okay, and it's becoming kind of a bigger and bigger issue, kind of as in our population. So the typical diagnosis is whenever someone has an elevated systolic pressure. So remember, systolic pressure is the maximum or peak blood pressure that a person has as they go through their heart cycle. And so if your peak blood pressure is above 140 millimeters of mercury, or your diastolic pressure is above 90 millimeters of mercury, then that's clinically diagnosed as high blood pressure, right? So the typical kind of ideal blood pressure for most people is 120/80. So that's a systolic pressure of 120 millimeters of mercury and a diastolic pressure of 80 millimeters of mercury. Okay. So it's very common. And so if you kind of take the ratio of the population, I think a poll was done recently, or a pretty comprehensive poll in the UK that said about 1/3 of all adults in the UK suffer from high blood pressure. So that's a huge number. And the cause for hypertension is a result mostly of lifestyle factors. So excessive salt intake, reduced levels of exercise, and stress. These have all been linked and correlated with high blood pressure. Okay. So high blood pressure, the interesting thing is that, by itself, it's not necessarily a bad thing, but it is kind of a precursor to a lot of other really serious diseases, things like heart attack, stroke, kidney diseases, and aneurysms. So if you have high blood pressure, or if you know someone with high blood pressure, that's something that they have to deal with, because like the longer that they have high blood pressure, the more at risk they are of kind of these more serious things. Okay. And the main issue with high blood pressure is that, think of it like a pressurized system, like a pressurized fluid flow, right? The blood pressure represents kind of the amount of energy or the amount of work that the heart has to undergo to push blood through your system. Okay. So if you have high blood pressure, what that means that your heart has to squeeze extremely hard in order to push blood through your entire cardiovascular system. Right. And so over time, if your heart constantly has to be exerting this much effort, it's going to fatigue the heart, which can eventually lead to heart failure or a lot of these other types of diseases. Okay. So that's the main concern with high blood pressure, is that it puts a lot of strain on your heart to kind of, do the thing that it needs to do. Okay? Treatment for high blood pressure often involves lifestyle changes, and so if you go to a doctor and they diagnose you with high blood pressure, they're going to tell you you need to exercise more. You need to watch your diet. You need to reduce the amount of salt that you take in, reduce the amount of sugar, reduce the amount of fats. Try to increase your leafy vegetable intake, more fiber in your diet. So, for the most part, high blood pressure is treated with lifestyle changes. Okay, which strangely or strangely not, is probably one of the harder things for people to do. Okay, so let's dive a little bit deeper into this, and so let's look at our typical blood pressure waveform. So this is a waveform that we saw in class, a few weeks ago. So when measuring blood pressure, doctors are looking at a few things, right? So the first thing that they're looking at is one thing called the pulse pressure. So the pulse pressure is the difference between your systolic and diastolic pressure, right? And so if you look at your typical kind of pressure diagram here, your systolic pressure is the peak and the diastolic pressure is kind of the minimum here. And so the difference between the height, the peak and the trough, that is your pulse pressure, okay? So this value here, the difference between these two values is determined mostly by your stroke volume and the stiffness of your blood pressure, blood vessels, okay? So if you remember, so it was a while ago, so let's kind of define stroke volume again. So stroke volume is the volume of blood. It's the volume of blood that's ejected from your heart in a single heartbeat. Right. So each time your heart beats, right? So each time you hear the dunk in your cardiovascular system, that's your heart kind of squeezing itself out to kind of push blood through your system. So the stroke volume is basically the volume of blood that comes out. Okay. And so the bigger your stroke volume is, the higher your pulse pressure is. Okay. All right, so that's one thing that they're looking at. The other value that they're looking at is the mean pressure. And of course, just like the name implies, the mean pressure is the time average blood pressure over one cardiac cycle. Okay. And so the mean pressure is determined by the cardiac output and the total vascular resistance of the capillary bed. Okay. So cardiac output, this is the mean flow rate, right? And our cardiac output is the amount of volume per time of blood that's ejected from the heart. Okay. And you see here that the other thing that we have here is a concept that's from lung parameter model. So the total vascular resistance of the capillary bed. Okay. So, we just got done talking about lung parameter networks, right? And so we've talked about resistance as being a function of viscosity in your blood vessels, right? So surprisingly, doctors actually use that same concept or that same idea. And so if you were to measure the resistance of the capillaries inside your body, right? And so you took, basically the radius and the viscosity and you computed their resistance. That's something that's actually really important for doctors to measure as well, okay? So this resistance right here is the exact same resistance or the exact same intuition that you can use from our lung parameter model, okay? Because what tends to happen as people get older, as they get diseased, is that a lot of these capillaries kind of get plugged up. They either get plugged up or they kind of get really narrow and really stiff. And so as the capillaries kind of get plugged up and really stiff, the resistance actually goes up, okay? And if the resistance goes up, that means the heart has to work that much harder to overcome that resistance to push blood through your capillaries to all the muscles and all the organs of your body. Okay. Okay. And so the relationship that we have between all these quantities is actually the same as our Ohm's law relationship. And so if you look at this formula here, this formula, of course, is given in words, but we have the formula of mean arterial pressure, P, is equal to cardiac output being the flow rate of blood in your cardiovascular system, multiplied by the resistance. So you have P is equal to QR. And if you kind of, remind yourself from our lung parameter modeling, this is the same thing as our Ohm's law relationship. In other words, the relationship between flow and pressure inside your cardiovascular system, okay? Which I have it right here. Okay. So this understanding of kind of Ohm's law and resistance and kind of what that means for the flow rate and blood pressure, is actually very important to see. Because if a patient comes in with high blood pressure, the doctor is looking at two things. And so if a patient has high blood pressure, they're looking at the patient's cardiac output. In other words, how much volume of blood is coming out of the person's heart. Okay. Usually this doesn't change all that much unless the person actually has heart failure. So, then the cardiac output tends to go down. But it's very rare for people to have an abnormally high cardiac output. And so if we know that this is relatively constant, right, for most people, then a person with high blood pressure must mean that they have a very high vascular resistance or an abnormally high vascular resistance. Okay. And so that usually indicates some issue with the capillary bed or maybe some issue with kind of the smaller vessels that either become really stiff or really narrow. Okay. So that's kind of the the fluid mechanics behind high blood pressure, right? So high blood pressure is a result of this resistance quantity that we have here. Any questions on this? Okay. All right, so let's talk about some different cases, right? And so the principal cause, or at least the most common cause for hypertension, really depends on the age of the patient, right? So for young adults and kids that have high blood pressure, this usually takes the form of what's called isolated systolic hypertension. And so that all that means is that your systolic your systolic pressure, the peak here is abnormally high, but your diastolic pressure is mostly normal. Okay. So this can happen for kids that have very high stroke volumes. Either they're actually very active in sports, or they're very active actively, and so their heart just naturally just pumps a lot of blood. So in those situations, your systolic pressure may be elevated. Okay, because for kids, for young people, it's actually very rare for their resistance to become degraded or to be elevated. Because they're still young, their cardiovascular system is still quite flexible. And so it's rare for them to have issues with their vascular resistance. And so when they do have a high blood pressure, it's usually due to, their heart actually becoming especially active. Okay. So for middle-aged adults, so this is the majority of high blood pressure patients. These are, people in their late 20s all the way up until their, late 50s. If they have high blood pressure, it's often called mixed hypertension, where both the systolic and diastolic pressure are raised. Okay. And this is the most common type of hypertension. And so this is a result of your capillary bed either narrowing or becoming stiff, which increases the overall vascular resistance of your system. Okay. All right. And then as you age even more, and so for even older patients, so these are patients that are age 70 and above, they tend to have a high blood pressure as well, but then it tends to show itself again as isolated systolic hypertension. Okay. But this is due to a different reason. It's because as you get older, your blood vessels just naturally get a lot stiffer. And so that tends to cause your systolic pressure to raise. Okay. And getting stiffer blood vessels is just a natural occurrence of getting older. So some people are kind of more resistant to it, but for the most part, most people get stiffer blood vessels as they get older, and their blood pressure tends to rise through no fault of the. Okay. All right. Any questions on this?
That first case, is that cause like health issues?
Usually not. Usually, I mean, if they have high blood pressure, then doctors will take a look at it. But if it's just because of elevated stroke volumes, then it's usually not a concern. Okay. But sometimes you might have kids that maybe they just had really bad diets growing up or something like that, or maybe they're exposed to a lot of like secondhand smoke or something like that. Then they may have high blood pressure due to other reasons. But so it's something to be looked at. But if it's just because of this, then that's not a concern. Yeah. Okay. All right. So let's talk a bit more about the role of vessel stiffness, because this is something that's going to occur to everyone at some point, right? And so if you remember, a few weeks ago when we were talking about arterial biomechanics, we talked about this wave propagation phenomenon, Okay, so just to kind of refresh your memory, because of the fact that your blood vessels are flexible, when your heart pumps, it sends not only blood through your system, but it sends these pressure waves that kind of propagate along your blood vessel walls. Okay, so we call this the wave propagation phenomenon. Okay, so remember the analogy that we gave was kind of like a pulse wave that travels on a string, right? So if you have a string, you pull it tight, you kind of pluck it, or you kind of perturb it a little bit. That causes a pulse wave to travel down the string. Okay. Eventually, this pulse wave will reach the capillary bed. And so once the wave reaches the capillary bed, then the capillary bed kind of acts like a wall, because your capillaries are just naturally a lot more stiff than your blood vessels. And so once the pulse wave hits the capillary bed, they then reflect backwards and then come back up through the tree. Okay. This reflected wave then comes and eventually meets the next forward wave, and then causing them to kind of add together, right? And so remember we talked about kind of two waves kind of meeting and they kind of interact, usually in a constructive way. Okay. So the main quantity that kind of changes as you get older is the speed at which the waves travel down the tree, right? Because generally speaking, as your blood vessels get stiffer, it's going to cause those waves to travel down faster. As the waves travel faster, that causes more reflections in your cardiovascular system, which eventually result in kind of added amplitudes and higher blood pressure. Okay, and so the older you are, or the more stiff your blood vessels are, you get faster wave propagation, which means more reflections and higher blood pressures. Okay, that's kind of a very short, kind of a hand wavy kind of explanation of it, but that's kind of the idea. Okay, so the younger you are, the slower the speeds go, and you're not going to have nearly as much reflection. So generally, younger people have lower blood pressures. Okay, and so you can see kind of an evolution here. And so I have 4 plots here. So this is theoretically this is the same person, although I don't think they actually measured these blood pressures 20 years apart. But you can see that as the person ages, they go from 18 to 40 to 60 to 80, right? We can relatively assume that this patient was relatively active, and so there's no other kind of outstanding health issues. But just naturally, as this person gets older, their blood pressure gets higher as well. Okay. All right. Any questions on this? Okay. All right. So next disease that we're going to talk about is atherosclerosis. And so atherosclerosis is a word that I almost never pronounce correctly. So you'll hear me pronounce it differently each time I say it. But this is plaque disease. And so this is probably a disease that everyone at least kind of, intuitively kind of understands, just because, there's been a lot of, I'd say, marketing and a lot of good outreach from the medical community, talking about the dangers of kind of high fat diets, high sugar diets. Okay. Because a lot of times it leads to conditions like this. Right? So the exact definition of atherosclerosis is the buildup of fatty deposits, which are called plaque, on the inside of the vessel wall. Right? And if it progresses to the point where the plaque it starts to really protrude into the blood vessel stream, it can cause narrowing and in the worst cases, blocking of blood vessels, which will restrict blood flow and reduces blood flow perfusion to critical areas of the body, like the heart and the brain. Okay. That by itself is bad, but I think the bigger risk that I think a lot of people don't know is that this plaque can actually rupture. Right? So you can't really see it from this image because this image isn't 100% accurate because it's essentially a cartoon. But in reality, when you have plaque that's built up in your body, there's actually a very thin layer of endothelial cells that are covering it. So your body actually kind of protects, or it kind of protects the fat, or it kind of encases it. Okay. What can happen sometimes is that endothelial layer can actually rupture. Okay. And so we call it like a plaque rupture in the bloodstream. So this is actually really bad, because then what happens then is that you have basically, when you have plaque is just kind of these really high concentrations of kind of fatty cells or fatty molecules, right? And so if the plaque ruptures, then those fatty cells then kind of get ejected into your bloodstream, right? And the thing with fat, from a chemical, from a molecular standpoint, fat is extremely sticky. They like to kind of stick to each other. And so the danger is that if a plaque ruptures and that fat gets out, that fat may get to a very critical part of your cardiovascular system, like maybe inside your heart, and really gum up and really kind of prevent blood from flowing in a very critical area. And so those are things that cause things like strokes and things like that. Okay. All right. And so the thing with atherosclerosis is that it's not an acute disease, and so it's not something that happens very quickly. And so plaque builds up in your body, and it's literally kind of a death by 1,000 cuts kind of thing. So if you have a poor diet or you're not physically active, then plaque is something that can develop as early as early childhood. And then if you don't really manage it well, if you don't really have a good lifestyle, then eventually it progresses steadily into your adult life, and then by that time it's usually too late. And so that's why you see a lot of advertisements and a lot of stress from doctors to really kind of maintain a healthy lifestyle while you're young, because that's kind of when you kind of build your foundation of health. Because once you get to adult and you start having issues, there's really only so much that you can do at that point. Okay. And atherosclerosis is kind of one of those diseases among a lot of other things that kind of progress kind of slowly over time. But a lot of times you don't really notice it until it's too late. Okay. But with that said, there are treatments, and so in extreme cases, there are things that we can do, and we are going to talk about them today. And so things like bypassing, things like stents, things like surgical removal. So you can do like an enderectomy. And so there are things that we can do, but these are typically not they're not usual, and they're very expensive and not comfortable, and these operations have their own risk as well. Okay. But atherosclerosis, I think, is a very stereotypical blood disease. And so you tell someone that you have a blood disease, this is probably something that a lot of people are going to be thinking. Okay. So let's talk, or let me kind of illustrate to you kind of how atherosclerosis kind of progresses. And so it's not really kind of what the cartoons kind of make it out to be. Because a lot of times, when you see atherosclerosis, it looks something like this, where, like you have plaque that's kind of just randomly kind of floating around in your bloodstream, and then it just kind of sticks to your walls. And so that's not, it's not 100% about how it happens. And so, atherosclerosis actually progresses within the blood vessel wall itself. And so what tends to happen is that, you start from a healthy blood vessel like this. And so ideally your blood vessel should be roughly circular in shape. And then if you have kind of high concentrations of fat either in your diet, or maybe you eat a lot of sugar, then fat starts to kind of show up kind of on the exteriors here. Okay. So the fat does travel through your bloodstream, but oftentimes the fat that's in your bloodstream are extremely small molecules. And so it takes a while actually for a large concentration of them to actually build up so that you can actually visualize it like this. Okay. But if you kind of maintain that lifestyle, you kind of have a lot of fat, you have a lot of cholesterol kind of floating around your system, a lot of it will tend to build up, and eventually you reach this phase right here, which is called intimal thickening, where the blood vessel wall actually thickens and more fat starts to deposit there. Okay. And atherosclerosis is kind of like a snowballing type of thing. So it starts out really slow, but then once it kind of gets going, then it kind of progresses fairly rapidly from there. Because once you proceed from this phase, then a lot of the fat molecules tend to kind of coalesce together, and you get this kind of big concentration of plaque right here. Okay. And then as it progresses even more, it may even, it gets even bigger, right? And so in this stage right here, it starts to actually affect your blood flow, because you can see that your lumen. The lumen is the portion of your blood vessel where the blood actually flows. You can actually start to see it getting restricted. Okay. And another big danger that can happen is that your plaque can also sometimes calcify, right? And so calcify, what that basically means, the plaque actually starts to harden and actually get really, really hard. And so once the plaque kind of gets, such a high concentration, that's really bad, because that you definitely don't want getting out into your bloodstream. Okay. And so eventually, what happens is that this cap right here, or this layer of blood vessel in between the plaque and the lumen, starts to degrade. Okay. And so once you kind of get to this stage right here, where the cap is really thin, that's when you're really at risk of the plaque rupturing and really causing some damage in your cardiovascular system. Okay. So again, it's a slow progressing disease, but it can definitely sneak up on you if you're not careful. Okay. All right. Any questions on this so far? Okay. All right, so what can happen from a biomechanics point of view? So biomechanically, whenever you have any narrowing in your blood vessel, that's a bad thing because that restricts blood flow, and causes your heart to work harder than it needs to. Okay. And so typically whenever you have a narrowing of your blood vessel due to atherosclerosis, we call that a stenosis. Okay. So a stenosis is a general term. And so a stenosis just refers to just a narrowing of the blood vessel. Okay. And so if you have a narrowing of the blood vessel, what's going to happen is that the cross-sectional area is going to constrict fairly rapidly. Okay. And so you can just use a very basic conservation of mass equation. So Q is equal to A times V. And what you'll see is that as you go through the stenosis, your blood is going to accelerate. Okay. It's just like a nozzle. In fact, it's basically the same thing. Okay. All right. And so when you have a stenosis, you have kind of a local acceleration of blood that goes through. Okay. That by itself is not the worst thing, although what tends to happen when you have the blood accelerate that quickly is that as you go through the stenosis, the shear stresses are actually very high here. Okay. Right. Remember, we talked a few weeks ago about shear stresses and kind of what they are and kind of and what they can do, right? And so you have some danger here of blood clotting because the shear stress may activate some platelets. Okay. But the bigger danger is actually what happens after the stenosis, because after the blood after the stenosis kind of converges, it actually diverges very quickly. And so, as the blood kind of passes through, you kind of have this development of a jet of blood that comes through. Okay. And so you have this concentrated stream of blood that comes through, but then in the regions that are kind of next to this jet, you kind of have slow recirculating flow. Okay. And so you have slow kind of what we call flow recirculation in those areas where the blood is either very slow or either kind of oscillates along. Okay. And so this recirculating flow actually can cause a lot of other issues because when you have recirculating flow, let me kind of clear these drawings to make it a bit more clear, right? In this recirculation zone, what you actually have is very low wall shear stress. Right. So when you have a stenosis, you have an area of very high shear stress in the neck of the stenosis, and then after the stenosis, you have low wall shear stress. You have elevated and then de-elevated wall shear stress. Right? And low wall shear stress, actually, believe it or not, can be a big issue as well. Right? Because remember, we've talked about before that on the inside of your blood vessels, and this is true for your stenosis as well, you have endothelial cells, right? And these cells, are living beings, and they can sense the mechanical environment in which they're exposed to, right? And so when you have cells that are experiencing shear stresses that are either too high or too low, right? We call that mechanotransduction. Then what happens is that these cells are going to adapt, right? And so what tends to happen then is that these cells will either grow, right? They'll continue to grow the stenosis, or they may shrink, which would cause this cap to rupture and plaque to come through. Okay. So it's a very volatile situation. And so it's one that you generally want to avoid in your cardiovascular system because it has a lot of really adverse effects. Okay. Right. So high wall shear stress, low wall shear stress then. Okay. Right. Cells are very particular things. And so, they want to kind of experience the same wall shear stress all the time. And so if you kind of change their environment, then most of the time they're not going to be happy about it. Okay. And so on the bottom right here, you kind of see a picture of the velocity profile. And so what tends to happen is that you have this kind of boundary layer that forms where the flow is either very slow or recirculating in these zones. Okay. All right. Any questions on that? Okay. All right. So let's talk about the pressure going through a stenosis, right? So to force the blood to go through such a small narrowing like this, it actually takes quite a bit of work because, imagine, you can kind of imagine the analogy of, of a freeway, like you're driving on the freeway, then all of a sudden there's construction on one side, so all the cars have to converge into one, right? And so it takes a lot of work and takes a lot of effort to kind of make sure everyone gets to that point, right? And so it's the same thing in your cardiovascular system. And so if you have kind of a rapid narrowing like this, then your heart has to work that much harder to squeeze the blood through, okay? Because as you go through the stenosis here, as you go through the narrowing, there is a very large amount of energy loss due to the high amount of friction, the high amount of shear stress, and small turbulence effects as well, right? So the stenosis is bad on multiple levels, right? And actually, what you'll see is that if you measure the pressure, so if you stick a probe in your cardiovascular system and measure the pressure at multiple points, right, through the stenosis, what you're going to see is that as you go through the stenosis, the pressure actually rapidly drops, okay? Which indicates basically that you have a very bad narrowing in your cardiovascular system, okay? And so what's interesting is that doctors actually utilize this, and so there is a clinical quantity called fractional flow reserve, or FFR, that's basically the ratio of the fluid pressure upstream and downstream of a stenosis, okay? And so FFR, I don't know why I don't have the formula here. So FFR is actually the ratio of the upstream pressure, so P up, to the downstream pressure, P down. Okay. Where P up is the pressure upstream here, P up, and P down is the downstream pressure down here, P down. All right. And so what doctors have found out is that this metric right here is actually correlated to disease severity. And so if the FFR is less than 0.8, so if you have basically a 20% pressure drop as you go through a stenosis, then that's characterized as a very severe disease. And so so doctors have to go in and operate on these things. Okay. But if the FFR is greater than that, so if you have an FFR of like 0.9, 0.95, that's, doctors will say that's an area of concern, but it's not one that they're going to operate on right away. Okay? Which actually causes a lot of drama, actually, believe it or not. And so, because a lot of times when you have a disease like this, like it shows up in a scan. And so if you were to take a CT scan of it or an MRI of a person's blood vessels, you can actually see the narrowing quite a bit. And so what happens a lot is that doctors will kind of show these scans to their patients, right? All right, we found some disease here, but it's not bad enough, so I'm not going to do anything. But then the patient will look at that, they're like, are you serious? Like, you're not going to do something about that? Like, I might die from that. So, it's actually a big problem. And so doctors will actually kind of, they'll actually react to their patient's wishes, and sometimes they'll operate on a disease that probably didn't need to be operated on. And so, you have a lot of people kind of walking around with a lot of extra treatments that they may not have needed because of that. So it's called a false positive. Okay. All right. And so something that's kind of tangentially related to this, and so, and I only mentioned this just because, this is an engineering class, and so, I know you guys are kind of interested in working for companies like this. But there's a company that's actually based out in NorCal called HeartFlow that actually makes their money off this idea of fractional flow reserve, right? So to properly measure fractional flow reserve, you actually need to stick a pressure probe inside a person. So actually, stick a hole in someone, stick a catheter in there, work it up from their groin and push it over to their heart, which is not a comfortable process, and it's actually quite expensive as well. And so what HeartFlow does is that, they said, all right, what we're measuring here is essentially just pressure drop. And so, we can do that computation. So we can do that with simulations. And so they use technology that's very similar to what we use in this class in Vascular. And they run a simulation of a person's blood flow through a stenosis, and they can measure FFR without having to need an invasive test or to stick a catheter up someone's groin. And so that's kind of their main product. They have a few other products as well, but that's kind of their main thing. So HeartFlow is actually, it was actually started by someone that has relationships to my PhD lab, and so I know quite a few people that work there. So I'm actually trying to get someone. No promises yet. We're trying to work out the scheduling, but I'm trying to get one of my buddies that work there to give a talk at the end of this semester. So we'll see if that happens. But we're having some issues with the schedule. Okay. All right, so next let's talk about flow rate. So kind of on that same, on that same token, right? Not all atherosclerosis or not all narrowings are essentially bad. Okay. So just because you have a narrowing of your blood vessels doesn't mean that it's going to cause an issue right away. Okay. So another metric that doctors use to determine whether it's bad is the flow rate of blood through a stenosis. Okay. And what's interesting is that, if you look at kind of the progression of a disease, right? And so to read this, you kind of have to go backwards. And so, you kind of have to go this way, right? So on this side, we have the healthy vessels. Okay. So you have kind of a nice healthy lumen here, but then as the vessel gets more and more diseased, that gets kind of plugged up. Okay. And so naturally, as the vessel gets plugged up, it gets harder to push blood through it. But what's interesting is that your body can actually sense this. So your body can actually sense when you have disease in some of your blood vessels, and then it can actually start to compensate. And so some of your downstream vessels, we call those the arterioles. So the arterioles are kind of the smaller blood vessels, not quite at the capillaries yet, but kind of getting there, right? If the arterioles kind of start to sense that they're not getting as much blood as they need to because there is a disease upstream of them, they'll actually start to dilate on their own. So they'll actually start to get bigger, right? And so, what happens that, let's say that you start to get disease and your lumen starts to narrow in your bigger arteries, then your arterioles will actually start to dilate and get bigger to kind of help compensate this so that the total amount of cross-sectional area stays roughly the same. Okay. So even if you start to get some fairly severe disease, and so, if you look at this image right here, that's pretty severe right there. So your cross-sectional area has reduced by about 70% there. But it's you actually don't actually really feel it because the rest of your body kind of compensates for that. Okay. It's only when your blood vessel actually starts to narrow by more than 70%, when your arterioles cannot dilate anymore, that's when you really start to have issues with your blood flow. Okay. And so on the one hand, this is great. And so it's kind of one part of your body kind of having the back of another part, right? So if another part's starting to, narrow or not really do its job well, the other parts of your body can compensate. And so it shows that your body is quite resilient to a lot of these things. But it's also bad in the sense that, a lot of times people are walking around with a lot of disease and they don't really know it because the rest of their body is kind of compensating for it. Because if you get to this point right here, if you get to the point where, your blood vessels are so constricted that it's only a small dot is left, there's only so much that we can do kind of treatment wise to kind of get you back to where you need to be. So, so it's fascinating that the body can adjust itself, but, maybe some earlier indicators might be nice too, just so that it's because, when you're kind of at this point and to the right here, it's much easier to treat it. But if you're kind of at this point right here, and of course, when it's completely blocked off, that's really bad. That's really hard to kind of treat something as well. Okay. All right. So the point at which, where your blood vessels, your arterioles can no longer dilate anymore to compensate, we call that the critical stenosis. Okay. And the point of critical stenosis is kind of different for everyone. All right. Any questions on that? Okay. Okay. So let's talk a bit about how plaque actually gets initiated. So, the way atherosclerotic plaque kind of starts growing is when fatty deposits or lipids or cholesterol kind of deposits into your blood vessel walls. Okay. What's interesting is that there are certain regions or certain geometries within your blood vessels where this tends to happen a lot more common. Okay. So through a lot of research, what doctors have found out is that the regions of your body where plaque is more likely to start growing or to start depositing are regions where there are low wall shear stress. Okay. So for example, one of the most common places for plaque to start growing is at a bifurcation, in particular on the outer edges of the bifurcation. So on the two daughter vessels, kind of on their outer vessels. Okay. Because if you did the fluid mechanics of this, and so you measured the blood vessel or the blood velocity, and you took the derivative and you found the shear stress, what you'll find is that the regions that are kind of highlighted in white right here have very low wall shear stress, relative to other parts of the blood vessel. Okay. And so these are regions typically where fat cells will start to deposit. Okay. So that's something to look out for. And so for those of you, for your final projects that are working on, patients that have atherosclerosis, this is probably something that you want to measure. This is something that you want to grab from your simulation to say, these are areas that are at risk for atherosclerosis. Okay. All right, another interesting reason why these areas are higher risk of atherosclerosis is that the flow tends to kind of recirculate in these areas. And so, just to kind of give you an example here. So, blood's typically going to come this way. It's going to hit the bifurcation, okay? And then once it hits the bifurcation, the flow is going to split like this, okay? Because you kind of have a rapid kind of change of direction right here, what tends to happen is that the flow can kind of recirculate kind of locally in these kind of areas like this as well, okay? Mostly a result of kind of colliding with the bifurcation. It's not like you have a whirlpool here, but you have kind of flow that kind of oscillates, it kind of comes here and then kind of gets pushed over there. So it comes in, it reflects, and then it comes back and goes that way. Okay? Comes in, comes backwards a little bit, and then it gets pushed eventually that way. Okay. So there is another quantity that you can measure, something called oscillatory shear index, or OSI, that's also been highly correlated with plaque initiation. Okay. So OSI is another output that you can get from Simvascular. And so for those of you that have patients with atherosclerosis, OSI is another quantity that you're going to be interested in measuring. Okay. All right. Any questions on that? All right. So let's talk about rupture a bit more. Okay. So remember we talked about that. With atherosclerosis, one of the biggest risks is if the plaque actually ruptures and then these concentrated fat cells kind of start to get into your bloodstream, get like other parts of your body. Okay. All right, but your body's going to do everything that it can to actually prevent that from happening. So in the early stages of atherosclerosis, the plaque actually grows outwards, and so instead of growing into the lumen, instead of growing into the bloodstream, it tries to store the fat outside. Okay. And so if you're the vessel wall and you start to see that, I'm getting all these cholesterol cells, I'm getting all these cholesterol molecules, right? It's going to try to store them outside so that it doesn't impede your blood flow, okay? Eventually, it'll reach a point where it can't store any more cholesterol, any more lipid cells on the outside. And so at that point, the plaque is going to start to grow inward, okay? And then this kind of bump starts to form. So almost always the plaque kind of forms kind of like a bump shape like this, okay? And if you look at this bump, we can kind of break it down into two different sides right here. So on one side, we call it the upstream side. Okay? And so on the upstream side, that's kind of exposed to a lot of the wall shear stresses here, okay? And then we have the downstream side down here. All right, so on the upstream side, we have high wall shear stress, and on the downstream side, we have low wall shear stress. Okay? It's a very interesting, very local kind of situation. Okay, and so you can see here that on the upstream side, you have a very, very thin blood, endothelial cap right here, right? Because the high wall shear stress, it causes the cells to kind of become thinner. Okay, and so if you're going to have a rupture, for the most part, it happens on the upstream side of a stenosis. Okay. Whereas the downstream side, you have much thicker walls here. Okay? And that's a result kind of purely of the fluid mechanics of the situation. Okay. All right. And so again, if a plaque ruptures, then it triggers, platelets to clot, and that can cause a lot of issues like strokes, heart attacks, things like that. Okay. All right. Any questions on that? All right, let's talk treatments. And so, what are some options to treat if you have plaque disease or if you have atherosclerosis? Okay. So typically a doctor won't go in and do any kind of treatment unless it's extremely severe, so severe that you're going to die tomorrow if we don't treat this. Okay. But oftentimes, if you're going to go to the doctor for plaque disease, it's because you've started noticing symptoms. You started getting shortness of breath. You started getting, you feel your heart rate kind of pumping up, or you feel your blood pressure starting to get really high. Okay. And so if you're going to the doctor and you have symptoms, then by that point, the plaque is probably really severe. But I would say that a lot of people probably to some degree have some kind of plaque that's kind of floating around inside the body. Okay. But if you do happen to catch it at a time when you can do something about it, there are some options here, right? So the most common one actually is number 2. So the second one is what we call pharmacological treatments, or in other words, drugs or medicine. Okay. So my dad has been on high cholesterol medicine for, I think, probably the last 15 years. And so, he has just naturally high cholesterol. And so he takes medicine each day to kind of lower that cholesterol, try to manage it. Okay. And so what a lot of those drugs will do is that your body can actually process cholesterol, right? But there's only a limited amount that your liver can handle before it start to actually propagate in your bloodstream. And so what those drugs actually do is that they actually kind of help your liver function, and so it helps them, kind of gives them some extra resources so that it can process cholesterol and kind of put it in a form so that you can actually pee it out or poop it out. And so it kind of helps to kind of lower the amount of cholesterol that way, just by helping your liver, basically. Because otherwise, for those people that have high cholesterol, their liver is kind of oversaturated with cholesterol, and there's not really much they can do at that point. Okay. But for those people who already have kind of a high amount of plaque, there is some treatments that you can do. And so the first type of treatment is, literally just go in and take it out, right? So what they'll do is they'll open up a person's blood vessel and they'll see all the plaque, and they'll try to literally kind of scrape it away from their blood vessel walls, which is kind of crazy to think about. So the most common place, or the most safe place for people to do this, is actually in your carotid arteries. So your carotid arteries are the blood vessels that go up to your head and your brain. Okay, so very important blood vessels. And the reason they can do this is because the carotids are actually quite accessible through your neck, right? So it's easy for doctors kind of access this. So this procedure, where they actually remove plaque kind of directly, they just go in and they just take it out, they scrape it out, is called an endarterectomy, or in other words, a carotid endarterectomy. Okay. Okay, another common treatment is to use angioplasty or a stent. Okay. And so for cases when you have a large amount of plaque in a very sensitive blood vessel, so maybe the blood vessels around your heart, like your coronary arteries, they may insert a stent. And so if you don't know, a stent is kind of this wire mesh kind of thing that they can insert into your blood vessels and kind of push it to the side, right? Angioplasty is kind of similar, but angioplasty is a balloon. So they actually put a balloon into your blood vessel and kind of inflate it to kind of push it out. Okay. And so what this essentially does is it essentially, and there's no better way to put it, but they kind of smush the plaque kind of back into your blood vessel. And so, if you have a situation where your blood vessel is very thin, plaque is starting to constrict it, they'll insert a stent and they'll expand the balloon and kind of smush it back and say, go back from whence you came. And they'll kind of push the plaque back so that your blood can actually flow through that blood vessel just fine. Okay. And then sometimes, if it's in a very critical area, they'll actually leave the stent inside there. So they'll leave kind of a wire mesh inside your blood vessel to kind of prevent the plaque from restenosis, basically. Okay. All right. And so the most extreme, probably the most, endarterectomies are pretty extreme, but another really extreme procedure that can be done is called a bypass surgery. So if you have plaque that's so severe, let's say that you have a plaque right here, where it's so severe that it's going to be really hard to repair, or what's more common is that you have plaque in kind of multiple areas. Then what doctors will actually do is they'll actually bypass it. And so the idea behind a bypass is that the blood has to get downstream of the plaque by some way, right? And so what doctors will do is they'll take another blood vessel and kind of attach it downstream of the plaque to make sure that blood can actually perfuse down into the blood vessels down here. Okay. Right. So this is called a bypass surgery. And so that's an extreme case where you have kind of a lot of plaque disease around your heart. Okay. All right. Any questions on this?
method of just like physically removing the plaque?
It's hard, and so I think the danger is that if you remove it or if you touch it, it may rupture. And then because it's an actively flowing system, then the plaque will kind of get downstream and you can't really control it. So exactly, yeah. So they can do it in the carotid just because geometrically the carotid's in a very special place where they can kind of scrape it and kind of catch it before it gets anywhere else. But that's really hard to do in a lot of other parts of your body. So yeah. Okay. Okay. So I don't think we'll get to all the medical devices today, but I at least want to talk about aneurysms. But aneurysms are extremely fascinating. They're fascinating in the sense that we actually don't know that much about them. So an aneurysm, you may have heard the term aneurysm from a meme or some point. Don't get an aneurysm, but an aneurysm is a local swelling of a blood vessel that becomes bigger, right? And so visually, it kind of looks like your blood vessel has like an extra sac. Okay. So there's two types of aneurysms, and so there is a fusiform aneurysm. So these kind of grow kind of in line with the vessel, and so you kind of have, it almost looks like your blood vessel kind of gets bloated at some case, right? So B here looks like a blood vessel that's like 7 months pregnant. The other type of blood vessel is a saccular type of blood vessel where this kind of forms to the side, and so you have kind of an appendage of blood that kind of forms that's not naturally part of your blood vessel geometry. Okay. Okay, and so just like plaque, and honestly, just like a lot of diseases, the primary danger for an aneurysm is rupture. Okay, but the rupture here is a little bit different, and so what you have here is this is actually your native blood vessel wall that's on the outside here, and so if your aneurysm ruptures, and so if a hole gets punctured through it, then you actually have blood that actually leaks out from your cardiovascular system, start to have really extreme bleeding. So that's extremely bad, especially if it happens in the wrong place. And so, we'll talk about cerebral aneurysms in a second, but a very common place for aneurysms to form is actually inside your brain. And so if you have internal bleeding in your brain, that situation can get very bad for you very, very quickly. So that's pretty bad. The other danger for aneurysms is actually the opposite problem, which is thrombosis, which is the blood actually clotting. And so because these aneurysms, they're kind of these pictures don't really do it justice, but sometimes these changes in size can be very rapid. And so what you'll have is kind of very rapid changes in the wall shear stress. And so what can happen sometimes is that because of that, your platelets can actually start to activate, and then the blood can actually start to clot within the aneurysm itself. And so what tends to happen is that you have blood that clots like this, and then this clot's going to grow. And then eventually it plugs up your entire blood vessel, and then that's when really bad stuff can happen as well, right? So it's kind of two extreme cases here. And so on one hand, you have blood that's kind of ruptured and you have kind of internal bleeding. The other, you have kind of the opposite effect where the blood actually clots and it actually plugs up kind of a key blood vessel in the body, right? So aneurysms are bad, and kind of their activation, or at least visually, is all kind of geometric in sense. Okay. And so the interesting thing about aneurysms is that we know actually very little about how they form or why they form. So some risk factors that some scientists have found is that they're hereditary to a degree. And so if you have people in your family that have had aneurysms, in particular, there's a certain syndrome called Marfan syndrome. A couple of you will probably work on this for your final project, right? There's environmental factors as well, like maybe high blood pressure or secondhand smoking, right? There's some correlations with these, but nothing has been really strong. So I would say that and I've spent a lot of time kind of looking through the literature on aneurysms as well. There's not a lot of really convincing data in terms of what causes these. We just know that they happen, and they're very dangerous when they do. Okay. So let's talk about cerebral aneurysms, which are, I think, kind of the scariest ones out there. So cerebral aneurysms are one of the most common forms, and these are kind of blood sacs that form in the blood vessels in your brain, okay? And what's scary about them is that they're actually extremely common. And so, anywhere between 4 to 6% of adults over the age of 30 have a cerebral aneurysm. And so it's very likely that actually someone in this room, at least one person in this room, actually has a cerebral aneurysm. They just don't know it, right? But the good thing is that, even if you have a cerebral aneurysms, most of them, are harmless, right? And so by itself, having an extra sac of blood in your brain is not that big a deal, right? If it's just a sac and it's just sitting there, that's fine. You can just, it's just chilling, right? The danger, of course, is that if this aneurysm ruptures or if it clots, then you have an issue, because then you have internal bleeding in your brain, or you have kind of or blood is clotted and blood doesn't get to a key part of your brain, right? And so if that happens, then your situation will degrade very, very quickly. So, in those cases where cerebral aneurysms do occur, the vast majority of these actually end up in either death or severe disability. So, it's very, very bad, right? The scary thing about these is that for the most part, these aneurysms are asymptomatic. So you will have no idea that you have them at all. So it's not like you get headaches. It's not like you get, high blood pressure or anything like that. And so most people that have cerebral aneurysms are walking around and they have no idea that they have them. And it's very hard to detect too. And so in order to really detect them, you need to do like a CT scan of your brain. And that's not something normally someone does. And so you don't go into, Kaiser Permanente and be like, oh, I need a CT scan of my brain. So, usually they're doing a CT scan or an MRI of your brain because you have something else going on. And so a lot of cerebral aneurysms were actually discovered by accident because, the doctors were scanning for something else and they happened to find a cerebral aneurysm. So, not the best news for someone. So let's say that you're going in, you're getting scanned for a brain tumor, and they find a brain tumor, and like, oh, by the way, you also have a cerebral aneurysm as well. So, not usually not a good thing. So, and in terms of geometry, most of these are saccular, and so these are almost always going to be a sac that kind of forms to the side of the blood vessel, and their diameters can range anywhere between 15 and 50 millimeters. Okay. Any questions on that so far? Okay. All right, so let's talk about the fluid mechanics of aneurysms, specifically the cerebral aneurysms, right? So because saccular aneurysms are not what I call conduit vessels, the blood is not forced to go through the aneurysm, right? There may be some geometries where blood kind of goes in because it's at a junction, but but for the most part, the blood can completely avoid the aneurysm and it wouldn't even know it. Okay. And so because of this, the blood actually enters and leaves the sac from the same place. And so we often call this the neck of the aneurysm. So the neck is, a portion like this, this portion right here. Okay. So that's where the blood both enters and leaves the aneurysm. Okay. So sometimes what can happen, depending on the geometry of the aneurysm, you may have a high velocity jet that actually impinges or pushes on the back of the aneurysm, right? And so it passes through the neck and then it forms a part. So actually this is probably the best illustration of it right here, okay? So you have a high velocity jet that kind of comes in, it's almost like a fire hose of blood, and then it hits just one particular spot, okay? And so you have one spot, basically a stagnation point here, where you have very high pressure and very high shear stress. Okay, and so of course that's always kind of a concern, because then if you have very high pressure and high wall shear stress in one part, that might be where, or that's likely where a rupture may occur. Okay. So in these kinds of aneurysms, the risk of thrombosis or blood clotting is quite low. It does still happen, but the primary concern is actually rupture. Okay. And rupture is something that you never want to happen. Okay. And the reason people get aneurysms so much in their brain is because of the vessel walls have, just because your brain has a very special kind of needs and anatomy, the blood vessels in your brain have a lot less elastin, and so they're much more softer, I guess you can say, and so they're kind of more likely to kind of expand like this, right? Not only that, but the geometry of the blood vessels in the brain, kind of the branching structure and kind of the tortuosity or the twisting of the blood vessels in the brain kind of encourages a lot of these things. Okay. So I'll tell you guys an interesting story. Interesting, but also kind of scary at the same time. So when I was in grad school, this was a very, very hot topic of research. It still kind of is. So people still are fascinated by aneurysms and they want to learn more. So this one group, they're from Canada, and so they put out a challenge. And so they had five patients who all had aneurysms in their brain. So they had a scan of their brain, they found an aneurysm. And some of these aneurysms ruptured, and some of them were safe, right? So these are patients that happened, 10, 15 years ago. So they just have the data for it, and they kind of know the outcome already, whether the patient lived or died, or they had rupture or not, right? And so they're interested in saying, like, these five patients are unique because we actually have a CT scan of these patients, and we know their clinical outcome. And so we were actually able to get an image before that happened. So they took this image data and then they sent it to all the leading labs in the areas of computational biomechanics. So all of the labs that do work with softwares like Symvascular, and they sent it to companies as well. And so their challenge was, they said, all right, here is the medical data for these patients. We want you guys to simulate the blood flow in these aneurysms, and we want you to predict whether the aneurysms are going to rupture or not. And we actually have the data that actually backs that up. So we can tell you if you're right or wrong, right? So you would think that, these are all extremely smart people, right? I was one of them. I'm extremely smart, who were given this challenge, and you would think that, some people would get it right, right? 0 people out of the 70-something groups that participated in it got all 5 correct. So no one guessed it right. And in fact, if you were to look at the data, it looks almost completely random. So half the people guessed rupture on one patient, half the people guessed rupture on the other patient. And so, I think they did an analysis afterward. They said, if you flipped a coin for every single patient and you said rupture or not, you would have done better than the average of what people did the simulations for. So, so for the record, our group, we got 4 out of 5 correct. So we were close, but we didn't get all of them right. But yeah, it was kind of a sobering experience, and so there were not a lot of happy people leaving that talk. So I'll say that. Yeah. So that was almost 10 years ago at this point, and so things have gotten a little bit better, but at the same time, there's a lot that we don't know about aneurysms still. So there's a lot that we can learn, but also it makes for a very interesting research topic as well. I think a lot of people are diving into it. All right, any questions on that? Okay, yeah.
And I would make the assumption that we're given an aneurysm that right there at the bifurcation point,
Mhm.
you would assume that to be more likely to rupture than these ones on the sidewall. Was that something seen in the?
You would think so. So a lot of people kind of guess that as well, but there's one that was like this. And so actually we'll go to the next slide here. Because one thing that people correlate a lot, or they're trying to correlate a lot with aneurysms, is shear stress. So shear stress is kind of like the main thing that people like to correlate with disease. The interesting thing with aneurysms is that the data is not very clear. So sometimes if you have high wall shear stress, that can lead to rupture. That's kind of what people intuitively think. But there's actually a lot of data where actually there are patients with low wall shear stress on their aneurysms, and those rupture. And so there's a lot of convincing data on kind of both sides. So that's kind of the interesting thing. And so actually the debates actually get very heated. And so if you go to a research conference where people talk about this, you'll have the camp of people that think high wall shear stress causes rupture, and you'll have the camp that thinks low wall shear stress causes rupture, and they hate each other. And then they actually argue and actually almost physically fight sometimes. And so because they both have cases, and they both have very kind of compelling data to kind of back up their cases. But when you have 2 sides with compelling data that show kind of conflicting things, I think the overall picture is that nobody really knows kind of what's causing this. And so people have tried to correlate the fluid mechanics. People have tried to correlate the geometry. Geometry is kind of the standard right now. So if you ask a doctor right now who's not heavily in the research, whether an aneurysm is at risk or not, they're just going to look purely by geometry, whether the aneurysm is big. I know they look at the overall size of the aneurysm. The bigger it is, the more at risk it is for rupture. They also look at the size of the neck actually too. So the bigger the aneurysm, but the smaller the neck, then those are more at risk for rupture. Yeah, but yeah, some people think high wall shear stress, some people think low wall shear stress. And there's compelling reasons for both. We're not going to get into it just because of the time, but there's a lot of really interesting data and a lot of very interesting theories that kind of go on as well. And I think the main challenge is that it's just so hard to get kind of a good, like a high amount of data with these things too, because these are, not, a very small percentage of people actually get scanned with cerebral aneurysms, and the ones that do, they have other issues associated with them as well. And so, you could say that, you have a data set that proves a certain point, but then there may be some complicating factor where, it may have affected some other thing, like they were smokers or something. So it's a very, very fascinating discussion. And I think until we can find a better way to kind of pre-screen for these, to make maybe CT scans or MRIs easier to get for people so that we can collect more data, I think it's something that's going to be debated for a really, really long time. Okay, so let's talk treatment, folks. We have about 5 more minutes. What's even crazier about all the theories for cerebral aneurysms is how they're actually treated, because these are actually very kind of brute forcey, if you ask me. So some of you wrote reports on this, and so some of you kind of already know kind of how aneurysms are treated. But let's go over kind of the 2 more common treatments. So the first treatment, this is kind of what they did a lot in the old days. It's called clipping. And so a clip is a literal kind of clip, like not that different from a paper clip. So they'll actually go in and they'll surgically open up a person, and they'll put like a binder clip on the aneurysm to kind of pinch it, almost like pinch it, and restrict blood from coming in. So this is done basically to make sure that no blood goes in there. And so if no blood goes in there, even if it ruptures, then it's all good. So, they don't actually like to cut out the aneurysm, because that can potentially damage the vessel wall kind of more than it needs to. So that's why clipping is kind of that thing. But the one that's kind of actually more common lately is something called coiling. And so in coiling, they actually go into the aneurysm and they insert this kind of metal coil. And so it kind of you create kind of as much interference in the aneurysm as you can. And so the idea with coiling is that, you create kind of all this interference, and it kind of encourages the blood to actually clot, kind of locally clot within the aneurysm itself. Okay. And oftentimes these coils are often coated with a drug that kind of encourages clotting as well. And so by clotting, and you try to kind of localize the clot to just the aneurysm, you kind of isolate this part of the blood vessel. So once it kind of clots, then it's kind of, it's kind of like a solid mass there. And so then it kind of stops becoming an issue. So very interesting treatment, and I would have loved to have been in the room with the person who thought of this, but that's kind of the standard of care right now, is to do these coils. But the dangerous thing though is that, even if an aneurysm is detected, and even if it's kind of classified as high risk, these treatments are not walks in the park either. And so these are fairly high risk treatments with a high chance of complications as well. And so it actually puts a lot of people in this kind of limbo area where, like, you have a person, they have an aneurysm, if it ruptures, they're probably dead. But if you operate on them, then, if you go in and you do something about it, that also puts them at risk of like infections, and which also may kill them as well. So, you have people kind of, I think for some people, I think it's not knowing you have an aneurysm may be better than knowing you have an aneurysm, because if you know you have an aneurysm and the doctor's not willing to treat it, then you almost kind of feels like you're kind of walking on borrowed time. So, yeah, very, very fascinating subject, but a lot that we can here. All right, any final questions on this? Okay. All right, so thank you guys for coming today. Thank you guys for listening to me rant on about aneurysms. I have a lot of thoughts on them. And so, so I think on Tuesday, I think we'll probably continue on with these lecture notes. There's a bit more on aneurysms I want to talk about, but I wanted more to get to the medical devices. Okay. So thank you guys for coming today. Make sure to choose your project topic by tomorrow. And I will send you guys the image data over the weekend. So hope you guys have a good rest of your day. Hope you guys have a good weekend, and I will see you guys next week.
So I'm actually listening to the how long is not yeah, I know that's the other thing. Yeah, it's just the thing is, I wanted to get the concept, and then after that, figure out split it up and then connect it. That's what I'm like. If we can Lego piece in the area, we'll have a chamber, we'll have a when you make these edgewise, so that you have it sitting on this edge, like that's facing down and currently that actually works. Yeah. Also, yeah, this.
What's up?
About the project.
Yep.
So I'm kind of between like number 3 and
Okay.
number 4.
Yep.
Which one?
I don't even know the answer.
Probably number 4, the cerebral ones, because these vessels kind of make a lot of twists and turns, they can be kind of hard to follow sometimes. And the thing that's even more difficult is actually the segmentation itself.
Oh, okay.
So this particular model, I know the person who made this, they were working on it for quite a time. So yeah, if you want one that's gonna be a little bit easier, number 4 is. Those vessels are much. Yeah.
This one? Yes. But wouldn't the geometry of this so it's challenging?
It'll be definitely much easier than the cerebral one for sure, because these vessels kind of just go in a straight line. So, I think the hardest thing with these projects is kind of knowing where to start. And so once you kind of find that first vessel, because I'm gonna give you a picture of the vessel like this too. Once you kind of find the first vessel and you kind of correlate, that's that vessel, then it becomes pretty easy. to kind of follow.
It's just smooth.
Yeah. I'd say number 4 is definitely much easier.
I'm kind of between
It's not
those two.
super.
Okay,
So
yeah.
I wanna decide.
Sure.
So which one I wanna do.
Yeah.
Like,
Thank you.
But you could still, even with just smooth, you can still just like. Go into it. Obviously, it's kind of lazy when you tell what the belly, you kind of, if it's a smooth shaft, it gets some kind of feel.